and the link will also be placed in the Zoom chat. You can also go to the website and key in the Slido code present to enter the Slido platform and ask your questions. Do note again that the speakers may be answering some of the questions during the talk, and the answers will also be on the Zoom chat. If you have any further questions, please feel free to post it on the Slido. Okay, so without further ado, I will now invite Dr. Chua to share her screen and start the session.
Hi, can everyone see my screen? Is it showing?
Yes, we can.
Yeah.
Yeah.
Hi. I'm Yi, one of the currently a senior resident in cardiology at National Heart Center. I did my preclinicals in Cambridge and my clinicals in Oxford, and I graduated in 2017. I didn't do my F1 in the UK. I came straight back. Though I know one or two people who did do their F1 there. For today, I'm just going to kind of run through what's a daily routine for house officer in Singapore and some of the skills that you might need and what's expected. Feel free to jump in at any point in time to ask questions, and then later some of my colleagues who are a little bit closer to housemanship will join us, and you can ask them questions as well. But overall, I would say that the expectations probably hasn't really changed much since I was the HO. So I think it would still be relevant lah. So I mean, in general, do be prepared by knowing what to expect. You can find out a bit more from your team when closer to the date, when you actually know which team you're joining, what time do they want to start, what do they expect, and get a handover. Shadowing ward rounds prior to starting, I believe that they do organize, but it might just be 1 or 2 days prior to starting. If you do like electives in Singapore, that might give you an idea, but I wouldn't say it's necessarily compulsory lah. Yeah, and some of the hospitals here are quite big, so you need to orientate yourself and know where you're going in order to save time. So do be proactive at the start of your posting. Do set out what you want to learn, and if you are unsure, just ask. It's better to ask and rather than assume and then be wrong about it because you didn't dare to ask. And do read up in between because there'll be lots to learn. Yeah. There'll be procedures as well, regardless of whichever posting. You should take the opportunity to do them as well. Sometimes they may not, seniors may not automatically offer a procedure to you to do, but you can always ask, whether if you're keen to give it a try. And then you need to start preparing yourself to be an MO even when you're a HO, because actually HO year is quite short, it's only 1 year. Yeah. Be collegial, so work together with your teammates. You have to work together with the physios and occupational therapists and the nurses as well. And if you help them, they will also help you lah. Yeah. And then you sometimes have to make sacrifices for other people, just as like how at other times other people also have to make sacrifices for you. So be prepared, be proactive, be collegial, and you need common sense, which is not always so common. So things are probably the same in a sense that everyone has to do at least 1 medical posting, 1 surgical posting. And then you can also do like obs and gynae or peds. And surgical posting you can either do ortho or GS. They do allow you to opt what you prefer, though I think you may not always get what you want lah. Yeah. So no matter what, if let's say you really hate medicine or you really hate surgery, you can't avoid it entirely. So for surgical house officers, usually we start quite early. Some teams can start like rounds at like 7, some at 8. So it really depends on your line, depends on the team or that day, whether your bosses have to go to OT. Rounds are usually quite fast. So sometimes you just have to write down the changes on like a notepad and then later retrospectively edit the notes. And then do try and clarify during the rounds itself, because after that your bosses disappear off the OT, and then you might end up having doubts that you can't clarify until like quite a lot later lah. And they usually pay quite a lot of attention to the ins and outs, especially the drain outputs for a lot of the surgeries. And do follow through lah. When they want. Don't know whether you have seen this SOOB. I've never seen it before coming to Singapore to work, but it's a sit out of bed 3 times a day, and then physio and occupational therapy. I think I would say bound to get scolded lah at some point in time as a surgical HO, but it's okay. Usually you are expected to carry certain things when you do GS, such as your blood tubes, your cannula. Sometimes it might make things easier. Your consent forms. Now manual listing forms not really, now it's all online. And green towels if you're in surgery, because if you open up wounds for your bosses to check, then because the nurses won't be able to dress immediately, sometimes you have to cover the wound temporarily with the so-called green towels, which are your sterile towels lah. And then you might want to carry a bit of dressing stuff with you, again, because your seniors might open up, and then you're expected to rip out these materials for them to use. Yeah. Proctoscope and KY jelly, the lubricant, again, for certain specialties like surgery, especially colorectal, you should have like one in your bag lah. These are some things that we commonly use. So like your insulin syringe, learn to recognize it because it's not same as your normal syringe. Your ABG syringe, culture bottle. So probably you should have seen some of this in the UK. So like the blue being the aerobic, and then the orange one being the anaerobic bottle, and the red one being the fungal or mycobacterial bottle, which we use sometimes for immunocompromised patients or patients who have had quite big abdominal surgery. Sometimes they're quite prone to fungemia also. And there's usually in surgery, there's usually a list. So they create a little table which has a list of the patients, the location, the past medical history, the IOs and the plans. So the location and where you put them is very important, because the bosses will follow based on what you've written as the location. What antibiotics is the patient on? This is post-op day, whatever. And the past medical history, investigations, and any plans lah. We do try to keep it summarized also, because if it's very long, then it's going to be quite hard to read through, and it do make sure it's accurate as well, because the bosses do actually look at it lah. So for example, it's usually comes something like that, a little tiny table, having all the necessary details that you need to know. And then at the end of it, traditionally, there's also a drink orders list for your bosses, because at the end of rounds, usually they go and grab a drink lah. So you usually have to think ahead, because apart from managing the patient for the day itself, you need to think about when you're going to let the patients go home. So you need to start thinking about discharge planning, TCUs being like the appointment. So for example, a patient was seen by renal during the stay, and then you need to know whether they are for follow-up or not. Then if you only ask the renal doctor on the day of discharge, you might end up having to wait around for the follow-up. So do plan ahead and obtain the follow-up dates early. Yeah. You don't want to be asking like on a Saturday or Sunday. No one's going to reply you. So sometimes they quite commonly ask for anesthesia or cardio review before the operation. So it might be worth asking if you think that the patient may need, or just clarifying with your boss. Sometimes they assume, and then you assume that they assume that you know there's a need to, and then you assume that there's no need to, and then ends up having a lot of last minute work for everyone. So what time to come in? I mean, depends on what time your team's starting. And when you first start out, you might have to come in earlier. The good thing about things nowadays, last time it's quite hard to claim, but now they have corporate Grab. So actually, if you arrive in hospital before 6:30, you can claim lah. Yeah. So this depends on your team, but they start anywhere between 7 to 8. And then they finish rounds quite quickly, and they kind of round up and have coffee together. Sometimes they run the plans through the plans together as a team. Sometimes they don't, but it's a good opportunity to clarify anything that you're not sure of. And then after that, you start doing your changes. Then usually you exit sometime in the afternoon. If your bosses are starting OT, sometimes this can be as late as 5 something lah. So do go through your list again on your own before your bosses exit with you, so that and review any patients whom you think might need reviewing. For example, those who have come back from procedures, or those who are a little bit who are not so well, those who had a fever, so that you can tell your boss when during exit rounds lah. And then in the ideal world, you go home at 5 o'clock, which may not be the case. Remember to prepare your list for next day, so that it's not such a rush in the morning, and hand over whatever you need to, and prepare the charges as well, so that your next day will be a bit easier lah. So by the end of the GS posting, you'll be the following, and hopefully you also learn some surgical things like recognizing and managing acute abdomen, stoma, strains, wounds, dressing, and sometimes you can scrub into OT as well if you are surgically inclined. Usually there are some opportunities in certain postings. In general, it's a bit busier than medical, I would say, but there are overall also there are quite a lot of good learning opportunities lah. So I'm not sure if anyone has any particular questions about surgical HO. If not, I'll just kind of run through what's expected in medical, but I mean, feel free to stop me at any point in time. Let me just close this. Medical, I would say in general, is slower pace, slightly different expectations. It's not so much about doing jobs and following jobs. People do expect you to come up with some of your own plans, and there's a lot more, probably a lot more communication and clinical reasoning required. It does also take a bit longer in terms of rounds. The focus is different now. So pre-rounding, there's no more handwritten. Changi Hospital was, I think, one of the last hospitals to transit to computers, but even now it's all on the computer, so that's a good thing. But the bad thing about computer is everyone tends to copy and paste lah. And you should, I'm sure in medical school they teach you SOAP, subjective objective assessment plan. So you should still try to do that. I'm not sure in the UK how much of it's handwritten still and how much of it's on the computer, but when it's handwritten, if you all have experienced that before, you don't want to spend your whole morning writing long notes lah. So you really have to summarize. And the practice nowadays is that people tend to just copy and paste the whole long past medical history or the whole history of presenting complaint into every ward round note. But I would encourage you to still try to do the SOAP properly lah. As part of the A is your problem list, so do revise it and prioritize it according to what's the most important. So if a patient comes in at night, they come out with their own assessment and what's the impression, then over the next few days, as more investigations are done, that should become more refined as more results become available, and you should keep it updated lah. Because ultimately then your plan depends on what is your A. So formulate your problem list well, include both medical and non-medical issues. Commonly discharged issues are present. And apart from the acute issue, you should also focus on chronic issues. So if a patient comes in with, let's say, some sort of cellulitis, and then you should think about, oh, actually they have diabetes, and is that well managed? Have they been screened for their microvascular complications? Are they getting their regular foot and eye screening? Have they been to podiatrists? So in surgery, often these bits are not really taken care of because the focus is really mainly just a surgical issue. But in medical, you are expected to think about these other things as well. So quite a lot of patients you see are frequent flyers, and you as a medical team, you should focus on how you reduce the recurrent admissions, and also focus on speaking to the families to see if they have adequate support, if they have any other concerns as well. So what do I mean by problem list? So for example, you have a 70-year-old lady who comes in pre-morbidly quite good with past medical history of the following: ischemic heart disease, previous inferior STEMI, post PCI to the RCA, diabetes. You should know roughly what's the last A1C, hypertension, hyperlipidemia, CKD, and transient ischemic attack. So presented with this, which is a green sputum, fever, left-sided rib pain, and the impression is that of a left-sided community-acquired pneumonia with a CURB 65 score of 2. As a result of the pneumonia, the PT has informed you that she's deconditioned and it's not at the baseline. And after speaking to the family, you realize that she lives with the elder son and she has always been looking after herself. So what are the issues in this patient? I mean, she has a pneumonia, but when you are managing inpatients, you also must think about how she's going to get home. So deconditioning and care is another problem. And then you need to think about what are your considerations in terms of discharge. So remember we spoke about being collegial and communicating well with your other colleagues. So you need to probably speak to the physio to find out when they say she's deconditioned, how much rehab does she require, what kind of rehab does she require, and what are the rehab goals. So yeah, we said she has a pneumonia, and then she has the atypical chest pain, and then some functional decline. The background, whether you put it at the start, whether you put it at the bottom, it doesn't really matter. So for everyone, for this one, this example, the team had already updated the family to find out what's the baseline and hence the potential discharge issues. So if there are very clear-cut ones, like in this case, where she just needs some rehab, may not need a social worker, but for those more complicated ones, we can consider getting the social worker in. And then remember we said we have to assess how much rehab, what kind of rehab does the patient need. So that's usually advised by the physio and the OT. Is there support at home? If there's good support at home, maybe let the patient go back home with a caregiver or have some sort of day services. The other thing when I came back to Singapore and I found it a bit difficult is all these acronyms and what kind of services are available. So CGT is short, stands for caregiver training. So if it's just a bit of caregiver training by the physio and OT to learn how to safely transfer or safely supervise the patient, that can be done in the ward, then they can go home from there. Transition care services. Now, sometimes there's a transition care facility. So if the helper, the caregiver is away for just a short while, the social worker can help to apply for transition care services to temporarily lodge the patient there. There's home medical and home nursing. So like patients who go home with an NGT or IDC, they can go back with, you can apply for home nursing, and then home medical are for those people who are immobile, can never make it to polyclinic. Then the medical team can go to their house. Daycare or day rehab, it's like literally like childcare center, but for the older patients. Rehab is usually not the full day, usually a few hours, but the daycare and day rehab centers are usually at the same place. So they can have either or both. Then if let's say they can't go home yet, they need like full-time rehab, there's no one to care for them at home, then a community hospital is possible, but there must be some sort of long-term care plan. They can only go there for 28 days in general. If not, you have to consider a nursing home. And then the other thing that I didn't realize until I started work is my consultant asked me if the patient's applying for a voluntary or private nursing home. So the main difference is that, of course, the VNH is cheaper for the family. A private nursing home is quite expensive. And then for private, it's very quick to get a spot, but VNH usually takes a lot longer time. And it's probably because it's subsidized. So each hospital tends to have their own community hospital. So for SingHealth, you have Bright Vision, which is near Sengkang side, and then you have Outram Community Hospital now. SA St Andrews Community Hospital is together with Changi General Hospital. Jurong Community Hospital is with Fong Teng Fong. YCH is with, I don't know who put that, but I think Ang Mo Kio is the one with dialysis. So patients hemodialysis all have to go to Ang Mo Kio. So over time, you just kind of like get a rough idea of where do you think patients should go. But if you're not sure, you can always ask your colleagues, or if not, ask the social worker for some help. So kind of briefly talked about daycare, day rehab. They're just centers. There are quite a lot of centers, different centers in Singapore. Usually it's not immediate, so the patients apply. They usually have to go home with some sort of home arrangement first before the daycare or day rehab application goes through and they get a slot. There's a bit of lag time. interim care services need to be applied through the social worker. So they usually have to apply, and then usually it's only subsidized for 2 weeks. So after that, the family have to sort out their own care plan. So it's just really temporary. For example, the family just wants some extra help at home with the helper because they think the helper needs a little bit of time to cope. Then that's when interim care services might be suitable. So we've also mentioned about voluntary nursing home. There's usually a criteria, and you do need a social worker to help the application. And then there are other community services like Meals on Wheels, where people go to the houses to deliver meals. And then there's home nursing, which there's like NGT and IDC change. So what is your routine as a medical house officer? You do get to start a little bit later, 6:30 or even 7 if you're, depending on how long your list and what time's your boss rounding. Rounds can start at 8, 8:30, sometimes 9. Again, depends on who's rounding. You may or may not finish at 10:30. I know some people round till like 2 o'clock. So, but I would say in general, you should finish by around 10 or 11 o'clock. And usually there's we have a drink together or round up. Again, an opportunity for you to clarify any plans that you're unclear of, and sometimes you do some teaching or chit chat during that time. Then you work on your cases, see new cases that land in your ward or the area that you're covering, and then review patients who needs reviewing. In general, if they're quite stable, you don't have to physically see them, but you should at least look through their charts to see whether they had any, whether their vital signs were okay, whether their blood glucose monitoring was okay, or whether they are or whether they're eating well. Yeah. Then you should, I mean, most of the time you should be able to finish by about 5, especially after you start getting used to the work, and then you can hand over and go home at hopefully at 5 something. Yeah. So the objectives for IM would be different. You should be familiar with managing chronic conditions and the basic acute medical conditions. You should have be able to come up with a good ward round note with a good problem list, and you should be able to communicate well with your allied health professionals, such as the social worker, your physios, and then come up with a plan. And it really gives you an opportunity to take ownership of your patient, and that's usually not overwhelmingly busy, so you can have some time to do some learning and reflection also. Any questions so far? I suppose not. So I mean, pre-round, just now we gave you a rough guide of what time you start, but again, depends on the list, how fast you round. You get faster through the year, and what time rounds are supposed to start. You should coordinate with your fellow colleagues about who's covering what and help each other out. So sometimes you have to cross cover, so you should ideally have a rough idea of the other patients who are on the list who are not necessarily yours. So what we've mentioned about ward rounds and SOAP. So what exactly do you need to write down in a ward round note? I don't know how much practice you have in your day-to-day work at the moment, but I would assume it's not that different in terms of what's expected. So your S is actually, apart from overnight events, is subjective, right? So what does the patient subjectively feel? O is like your objective things like your vital signs, how much has the patient taken, input, output, what are the examination findings, which you should edit from day to day. So as I said, with the copy and paste function, sometimes people copy and paste the exact same examination findings since admission. So like some people put like DRE, brown stools for like 5 days in a row, but clearly the patient isn't having DRE every day. Your assessment and impression that we kind of said to update every day, and the plans to do for the day. So when we say overnight events, how do you know? So apart from medical reviews, there's usually nursing handover notes that's documented all online, so it's very easy. Any suspects who came and reviewed the patient in the afternoon, and then any allied health input, but also the subjective part actually truly refers to the complaints or concerns of the patient, how the patient's feeling. Objective okay, we said vital signs, but what especially? Was there any fever? Was there any hypotension or hypertension? Was there anything wrong with the heart rate? Any desaturations? I think this one is quite straightforward. So not just fluid, not just drains, but also, and not just how much urine was passed, but also how much have they been eating and pooping as well, which are quite important, especially in the older patients. It can, or for example, patients with liver cirrhosis and where bowel output is quite important. Examination, I think this one shouldn't be much of an issue. It's probably something that you're very familiar with, but it's just going through the systems. And apart from the normal things that we cover, like your heart, your lungs, your abdomen, include anything else relevant. So if the patient come in for fluid overload, what's their JVP? If they have joint pain, is there any swelling or erythema or warmth? Or if the patient has had a fall, do they have a cephalohematoma? So do document what's relevant according to the presenting complaint. If the patient was charted to have black stools overnight, for example, then you might have to do a PR examination. Or if the patient has had a fall and who's come in, you might want to try do a neuro examination, postural blood pressure, and maybe check the patient's gait as well and walk the patient. Assessment, I guess we've kind of gone through that earlier as well. So every morning you should look through it and see whether it should be revised. You can put in the new relevant test results under that as well. So I think one of the easiest formats, if you're not sure what it is, so the symptoms, so for example, fever secondary to something else, so fever secondary to pneumonia, precipitated by may or may not be clear. Apart from precipitated by, the other thing you can think about is complicated by. So fever and cough secondary to pneumonia, complicated by SIADH, for example, or fever secondary to Staph aureus bacteremia, complicated by infective endocarditis with embolic phenomena. So you can always use this structure to come up with an issue list if you're not sure. It may not actually be a symptom. So for example, some people may be admitted for asymptomatic hyponatremia. So it could be hyponatremia secondary to SIADH. So these are some other examples. So apart from that, earlier one, the backgrounds that's relevant, you may also want to put it within the same issue list. So plans, the way to formulate plans is if you follow a certain structure. I feel that same with your ward rounds, but if you follow a certain structure, it'll be quite easy. And I encourage you to start doing this now, even before you start work, because it takes time to develop, to get used to having a structure actually, and get used to starting to formulate plans. And as you said earlier, HOE is quite short, so use this time to come up with good plans, because when you become MO, then you're the one coming up with the plans and finalizing the plans at night. So nursing, broadly speaking, can divide it into nursing, investigations, and certain management, including the medications. So nursings are like, how frequently do you want a vital signs to be monitored? What kind of diet? Is it NBM, or is the patient allowed to eat? Or is the patient allowed to eat? If the patient is known to have dysphagia, do they need like a blended diet? Do you need them to chart the IO strictly? Or do you need them to weigh the patient daily, for example, in fluid overload? Or if a patient came in with very severe hyponatremia, do they need to have a seizure chart? Are they allowed to move around? If they just came in a fall with a hip pain and you're waiting for the x-ray, maybe you want them to have a CRIB, complete rest in bed. Or if they have come in with a heart attack and they're on telemetry monitoring, are you going to allow them to go to the toilet? So these are things that you should put down if they're relevant. So investigations, as you do in your OSCE, so you must think of it systematically. So your blood tests, imaging, and any specialized tests. And management will include your medications, any procedures that are required, any referrals that you think need to be made, and discharge planning, as well as extent of care status lah. Kind of briefly mention also, when we round up, the purpose is for you to clarify any plans or management, an opportunity to clarify or ask questions for your own learning in general. And then as a HO, actually you need to learn how to collect your drink orders and order them lah. So usually the boss will just pass you some money to order up lah. So are you all familiar with this? I would think so. So some typical drink orders. Just remember to clarify whether the drinks are the same as usual. So you can, in your WhatsApp group for HOs, put down the drink orders, or for surgery, you can put it at the end of the list lah. So I would think that you roughly know this, or if not, when you have the slides later, you can have a look. So what kind of changes or jobs? Can't remember what's this referred to in the UK. I think jobs. Yeah, but the changes that we do are like procedures. So sometimes you need to insert IDC for patient, do special blood tests. So like toxicology or blood cultures can only be taken by doctors. Medication changes, you can try to do them during work rounds, but if you don't get to do them during rounds itself, then you need to do it. Remember, do it after, and then make referrals or update other specialties now. And always remember to update families. Good communication is a key to prevent complaints, and then you need to process your discharges also. So there are so many things for you to do. I mean, I think especially at the start, you're not sure where you should do. If you unable to prioritize, you might often feel quite overwhelmed because you suddenly have so many different things to do and not sure where to start. So think about which one is the most time sensitive. Referrals can be time sensitive. No one likes receiving a referral at 4 p.m. And after certain departments have slightly different cutoff time. So for example, it depends on the hospital. So be familiar of what the cutoff times are so that you don't end up missing the referral time. And so that you don't make the other department annoyed also. And different departments have, different hospitals have different policies about like whether you need to call in advance or whether you can just put it up online now. If you need to update another department, do try to do it early as well. And then certain blood tests might not need to be done at a certain time. And then discharges also should be early so that they can free up the bed for incoming patients. So the referrals used to be called blue letter because last time it was literally a paper that was blue in color. So referrals are still commonly referred to as blue letter, but it's just a referral lah. If you don't know why your team is referring, do clarify, because if you don't, then the person receiving the referral might end up calling you to clarify what's the reason for the referral. When you write a referral, so the most important thing is to state why you're referring the patient, what is the relevant past medical history, and what's the current issue. You should ideally have some sort of impression of your own so that you can show that the person you're referring to that you have thought about it lah. Yeah. So don't set it off before the deadline that's incomplete, just to avoid having to call the person. So if you miss the cutoff for the timing, sometimes you might end up having to call, but if you call, it's only for urgent one lah. So my advice is just to do it early, yeah, to avoid calling and avoid sending off an unfinished blue letter. When I started off as a HO, I was advised that when you write a referral letter, you just copy and paste the discharge summary and add a sentence about why you're referring. But then I don't think that's actually a very good way of doing discharge summary. So do try to summarize the actual pertinent points. Well, try not to write a single line unless there's really nothing to write about. If you are referring for pre-op risk assessment, which you'll commonly do from a surgical procedure, remember to write down what procedure exactly, what kind of anesthesia it is, and when is the op planned for, and how urgent is the op plan. So for example, right, dear colleague, thank you for seeing this patient, and then you're referring for what? what's the patient's background, why did the patient come in, he has a past history of what, which it must be relevant lah. So if the patient, for example, if the patient has, I don't know, a history of sinusitis in the past, it may not be so relevant. So when it says significant history, it should be the history that's relevant. So summarize what are the active issues and how is he currently and what's your impression. And again, why are you referring the patient? So it doesn't actually have to be very long. I think it should include things that are relevant. Okay, I don't know whether you all have any opportunity of working in or shadowing people in Singapore yet, but there's this thing called Tiger Tech. So you can essentially find most doctors on, I think, in fact, all the doctors on Tiger Tech, as well as allied health, nurses, physios, all on Tiger Tech. And there's also a read function, so you can see whether the person has read the message. But I feel that nowadays with Tiger Text, people like to text instead of calling. And I do think that calling should remain as a default. Now being on the receiving end of the updates, I still think it's quite important to call, because I think calling enables you to convey different kind of information, and then you don't have to type so many things, and the person also don't have to type so many things and reply. Of course, if the person's very busy and tells you to text instead, then that's different. But I think you should call as a default lah. Yeah. So when you call, well, yeah, you should introduce yourself lah. Who are you calling and why you're calling? Usually they have people don't have so much time to listen to you, so do get to the point and make sure they have the relevant information. So last time I call, I usually try to call with a computer at hand so that I can refer to the necessary results quickly. And when you update, you must again update with a purpose lah. So sometimes, again, if you're not sure why you're calling or what you're updating about, do check with your seniors before calling. Yeah. So for example, you can check if it's a good time. If they say no, it's not a good time, you can check, do you want me to call you back or do you want me to text you later? And then usually they'll let you know lah. So you should, they might have seen many patients across the week, so it'd be good if you remind them when did they see the patient, where's the patient, and what did they review the patient for. Or sometimes you might be calling for a review. Yeah. So I think accurate is important, being concise is important. And sometimes they don't have time to look through all the things that have happened in the past. So you should really summarize what has happened in the interims from the last review as well. So the discharge summaries, it's a bit like most people, the way that most people do it, to be honest, is they copy and paste the admission note. Then they copy and paste the issue list from the daily walk around note into the discharge summary, which I think is fine as long as it's actually accurate and you delete the relevant thing lah. So for example, some people's discharge summary would say things like history from ED is as follows, and then there's a history visited in the ward another time. Then there's a seen by the reg, and this is the history, and then seen by consultant, and this is the history. So you should summarize all the history into what's relevant into the final discharge summary. And the discharge summary, as the name suggests, is something that you have to do for all the patients. I think as a medical student, I don't recall doing any discharge summaries in the UK. And I think the ones that they do in the UK are much more brief than the ones that we do in Singapore. So I wouldn't worry too much about doing discharge summaries. I think you will learn on the job. Just remember to keep it summarized, have a read through it. And ultimately, these documents are also medical legal, and subsequently when patients request for medical report, what they refer back to actually is the discharge summary as well. The detailed one that you do are not received by the patients. They get a much shorter so-called patient copy, and just be careful about printing out the detailed copies to families as well, because they're supposed to only get the patient copy lah. Yeah. So the discharge summary, as I said, it's kind of a lot of people copy and paste in the admission note because it's pretty much the same format for the first half. So with the patient information and demographics, the thing I realized coming to Singapore is that, when you learn your OSCEs and how to take history, you do like demographics and then history of presenting complaint, then the past medical history and so on and so forth. But in Singapore, somehow the order is a little bit different. So it starts off with the demographics first, and then the past medical history, and then the last admission, then the presenting complaint, examination findings, investigations, issues, and progress. So the admission note as well as the discharge summaries generally follow this format. Yeah. And important to include any medication changes and any appointments or follow-up plans. So when we say demographics, includes things like age, gender, and race. How they are in terms of their ambulatory status, or whether they can perform their own activities or daily living. Again, it depends whether it's relevant. So some people some people are well, let's say if it's a 28-year-old, then it's not very relevant. So you have to see whether it's relevant for the patient before including it. Any allergies are also put at the top, and then whether they smoke, whether they drink, and who they live with, and extent of care usually all goes to the top. So a little bit different from how we are taught to clerk traditionally during OSCEs. Past medical history, we keep it updated and include the relevant things. Yeah, so like who are they follow up with, when were they last reviewed by, and the last admission, what was pertinent, so don't copy and paste the whole previous discharge summary in. So history of presenting complaint, generally you put the history taken by the primary doctor for the first day. If there are multiple people's history, then do summarize it into one history. Examination findings, take it from the first day as well. Investigations include investigations that were done on admission. And then issues and progress is pretty much like your problem list, but perhaps in a little bit more detail. At the end of it, you should include who was referred to, who was it seen by, and again, don't copy and paste the whole referral reply or the whole X-ray report or the whole CT scan report as well. Do keep it short. So medication changes, do remember to include it, because subsequently when they go back to polyclinic and all that, or if they're readmitted, it's much easier for the next doctor to see what was changed for the patient, and that might affect how they adjust the insulin, for example, subsequently. It's important to put why you change the medications as well. It's quite easy, I think, when you're on the computer and doing all the changes there, and I think in Singapore we often assume that patients don't know their medications very well, but sometimes actually they do, or sometimes their family do. So it's important to let the patient family know what changes were made. Yeah, Singapore, the follow-up appointments are called TCUs. So do ensure that if they've been referred to someone, check back with that subspecialty whether they need to be seen in the outpatient again. If you think they need the new referral outpatient, you're not sure, you can check with your seniors. You should clarify if they need any additional tests before the appointment. And sometimes seniors might assume that you know, or forget to tell you. So do clarify if you're not sure. So I usually do the discharge summary early, meaning like within the first 2 days or first 3 days of admission, and then maybe aim to update it before the weekend each week. Yeah. When you discharge patients, you're also expected to prescribe the discharge medication. So apart from listing what the changes are, you are expected to actually review the discharge medication. So when I first started, to be honest, I also didn't pay attention to everything. So I realized that and there's a copy and paste function for the duration of medication you would like to prescribe. So I'm definitely guilty of doing things like prescribing 3 months of paracetamol, which is quite unnecessary lah. So do remember that not all medications have the same duration. Do click through them one by one. Or if let's say someone's came in with hypokalemia, you do really need to think about whether it's from GI losses, then you only need to prescribe a short course. So again, avoid a prolonged duration. The pharmacists are usually quite good at picking up these sort of errors. Certain things that are not say harmful per se, like the 3 months of paracetamol, they'll probably let it go, but it's good practice to still look through your medications line by line. Any questions so far? I think some of you are a bit more junior, so this might all seem quite far away from you. I think clocking new patients, I guess you do get to experience that when you are on take with the medical team. You do have to clock patients during the day when they come to your team, as well as when you're on call. And if you think about how the hospital works, is such that a lot of patients are actually admitted when you're on call in the evening. So the evening time is when most of the patients come. So if the patient has some sort of symptoms, they come in, they go to the GP or polyclinic first, who then refers them to A&E. So by the time they're actually admitted, most of them are actually admitted in the evening. So A&E doctors who have seen them once, and usually they have some sort of note up, but your duty is actually to make sure that you put up an accurate admission note with the correct details. So don't just copy the A&E note lah. If you don't put in anything false, so if you didn't ask the patient something, don't write it in. Always verify. Don't assume what A&E has clocked is correct. So always verify the presenting complaint and revisit the history again. Don't order up medications or investigations before seeing the patient. And this applies also to your CTSPs in the middle of the night. Okay. So when your phone rings at night and the nurse tells you that you have a new patient to be clocked, take down the details and the location. Details being like name and NRIC, and that's because by the time you get to the patient, it might be an hour later and the patient might have moved, and you certainly don't want to waste your time clocking a patient who doesn't belong to you. I would add that you should actually verify that you are actually covering the patient. It's not uncommon where you are medical and they're calling you for a non-medical patient. So make sure that you're actually the correct doctor to be called. So find out whether they can tell you what's the patient admitted for, so that you get a rough idea of how urgent you need to see the patient and how you can prioritize. Ask them what the vital signs are. Unfortunately, sometimes now there's an early warning system, which I think they use in the UK as well. So now they're using it in Singapore. So in some hospitals, so maybe that would be a bit better. But previously, I've had patients who are like 93% or 50% face mask, which is not great. But because it's more than 92%, the nurse actually told the team that the patient's stable. So do ask for the actual vital signs. And then when you're swamped, you can ask the nurses to do some simple investigations first. Yeah. So when you're on call, it's quite easy to miss patients out. You're not doing your MBBS exam. So you really need to prioritize. So if the patient, as this is an example that I've kind of put up. So if you are on 4 liters of oxygen, or if you're on face mask, then you are not well because patients require oxygen to even hit 97%. So just be very careful when the nurses tell you that the patient is stable, that you do check and verify that yourself. Okay. So something that I didn't do as a medical student in the UK, but it's quite common here, is kind of pre-clocking the patient. So a lot of people put up the notes before they even see the patient. And again, the format of admission note is the same as the discharge summary that we went through earlier. And you can look through the A&E admission to have a brief idea of what the patient came for. And you can also have a look through the preliminary investigations that A&E has done before seeing the patient. Whether you really want to put up the note before you see the patient or not, kind of up to you. But sometimes because you're the house officer on call and you have an MO as well, sometimes the MO also will see the patient. So all patients seen by HOs have to be seen by MOs as well at night. So quite often nowadays, if you don't have enough time to see the patient, and what does happen is that you put out a pre-clerk note and then your MOC and edits your note. So should you pre-clerk before you see the patient? I guess if you're already swamped, then you should, but if you have enough time, you can also quickly see the patient and put up the note at one go. Past medical history, much like the discharge summary, you should make sure it's accurate and up to date. So certain things that you might want to look out for example, in a patient with ischemic heart disease, whether there were any recent echoes, any PCI done, any devices such as ICD. For asthma and COPD, you want to summarize what's the extent of in terms of severity. So whether they have required intubation in the past or NIV, what kind of inhalers they're on, whether they had spirometries or was this just diagnosed by GP without actual spirometry. If there is anemia, what kind of anemia, when was the last iron panel, whether there was endoscopic evaluation in the past, if the ESRF, how do they dialyze, on what days, what's the dry weight, cirrhosis, you should always try and write down the etiology, what's the child flu score, any complications such as varicose bleed and cephalopathy. So probably you'll have more time to think about it during a medical posting, but whenever you look through someone's discharge summary, these are some things that, discharge summary, or when you clerk someone new, especially when you have a bit more time, you should try to summarize these properly. So again, when we said for diabetes, what's the last HbA1c, what's the medications, whether they've been, what kind of micro or macrovascular complications have they had, have they been getting their regular eye and foot screen. For oncology, you need to know what type, what cancer type, what stage, what therapies, what's their latest CTTAP, for example. And whether there are any previous extent of care discussions, which we commonly initiate in the elderly patients or patients who have multiple comorbidities when they're admitted, even though they don't have to be critically ill for us to start this discussion. If they were recently admitted for some sort of sepsis, looking at what kind of cultures previously were positive, if they are coming in with another episode of sepsis. So investigations, you need to look through what investigations are performed by A&E. If they've had a chest x-ray, you should look at a chest x-ray, because looking at chest x-rays are kind of like part of medical school teaching. Look through, to avoid double work, you should look through what the A&E do, including whether they've done the blood culture. So depending on which computer system you use, you should familiarize with yourself and how to double check what A&E has already done to avoid double work. So look through the results one by one. It's quite easy to miss certain things. So some examples here, like your cardiac enzymes, they're elevated and you may have missed it, or they have abnormal electrolytes, especially the bicarbonate. It's quite commonly missed for some reason, or hemoglobin was low. That might also have been missed. And in a full blood count, sometimes the differential for the white cells have been missed in the past. So there was a case where patient came in, went to polyclinic for a routine check, I think, and then or for some cough, she had a full blood count, which then showed that she had blast cells, so immature white blood cells, indicative of something like leukemia. So polyclinic rang her up because of the critical result to tell her to go in A&E. So A&E triage actually wrote that she was referred from the polyclinic. Polyclinic had called her to come for abnormal blood test results. So then A&E saw her, and then I think because there was some cough labeled, and then there was leukocytosis, she was labeled as having a pneumonia, and then she was admitted to the medical ward. And I mean, she didn't have leukocytosis, but the leukocytosis is from the blast. So then she's admitted to the medical team. Then the medical team treated her as one pneumonia and discharged her. And she's had at least 3 or 4 full blood counts by that time, showing leukocytosis from increased blast. But because the differentials are right at the bottom. So I think no one really scrolled and looked through the differentials one by one. So the leukemia was actually missed. Yeah. So make sure you scroll through all the results one by one. When you see the patient, it's same as what you do learn for OSCEs for taking a history. Examine the relevant parts. So again, your examination shouldn't be a one size fits all. It should be tailored to the patient. And this should include looking at your vital signs as well. And then you formulate your problem list now. So problem list, remember, go by symptom or whatever the abnormal lab is first, then you label it as secondary to what the problem actually is, and then complicated by whatever complications the patient may have had. Okay. So your plan, I think when you first start out, you might find this a little bit more challenging because it's not something that we usually practice as a medical student, I feel. But I think when you go on medical takes, especially in your final year, you should start trying to see whether you can formulate some plans, and that will help prepare you for HOship. So when you talk about vital signs monitoring, you need to think about how frequently does the patient need to be monitored. Is the patient quite unwell? Is the patient tachycardic? Does the patient need frequency of monitoring? And I think what's not included here, but it's probably quite important, is where should the patient be monitored? If you think the patient is not safe enough to be in a normal ward, whether the patient needs closer monitoring, a high dependency, or even ICU if the patient is very unwell, then you need to escalate to your seniors to consider escalating the level of monitoring. The charts, what you want the nurses to chart, what kind of dietary requirements. So if the patient has DM, just put DM diet. If the patient comes in for BJIT, curry BJIT, maybe keep their meal by mouth until the morning. If the patient's overloaded, you want to specify how much fluid restriction you want the patient to be on. Other measurements that are to be done by nurses also go under that, including your capillary blood glucose monitoring, how often you want it to be done. It doesn't always have to be 3 times a day at 10 p.m. It may be less frequent or more frequent depending on what you think is required. So if the patient's on an IV insulin, for example, then you need it to be hourly. If the patient comes in with giddiness or fall, you might want to consider checking the postural blood pressure. If the patient has a bit distended abdomen or has some problems passing urine, that you might want to do the post-void residual urine. And remember that all these things, this is for clerking a new patient in admission note, but it's often something that everyone copy and paste into the daily workaround plan, and it should be reviewed daily. Like a patient who's come in with giddiness and then there's postural blood pressure had already been done a few times, it's normal, should consider stopping it. A patient coming who has a history of diabetes and it's been diabetes and the sugars have been very stable, you want to consider stopping it, because all these cost time to the nursing staff and actually cost money to the patient as well. And who you want to refer to can go up here or within the management plan later on. So any special precautions for patients who have swallowing problems, immobile, you might want to nurse them at 30 degrees. If they are immobile, you might need to turn them regularly to prevent bed sores. For patients who are immobile post-op, you might want to consider things like calf pumps. For old patients, you usually like to try and sit them out of bed 3 times a day. This SOB I've never seen in the UK. If they are quite elderly, they came from nursing home, you're not sure whether they are able to be on their own, then you might want to put them on supervised feeding for now also. It's important that you work well with the nurses. They actually do a lot of these changes for you. If you respect them, they'll respect you as well, and they'll help you along also. Yeah. So blood tests, when you see a new patient, think about what tests have already been done. Don't repeat the test unnecessarily. Think about what needs to be done now, whether they can be done in the morning the next day instead. What kind of basic imaging, and then if you think the patient needs a CT scan, for example, then do go through your seniors, and usually if you need them overnight, you need to speak to the duty radiologist on call also, and then liaise with the scan room to arrange the scan. So what kind of treatment to be rendered? In order to not miss out anything, I will usually refer back to the problem list. So make sure that there's a treatment plan for each problem within your problem list. And by doing that, you know that you've addressed all the problems. Yeah. Apart from treating the actual problem, symptomatic relief is also equally very important. Any referrals, if it's urgent overnight, again, something that you should discuss with your seniors before referring. And if they really need to be urgently referred to overnight, then don't text the person, do call the respective specialty overnight. Extent of care, if it's been established or you have already before in the past, you can also put it down at the bottom so that it's easy for everyone to refer to. So in summary, when you track a patient, don't copy and paste in e-note. If they're sick, do remember to see them. If you pre-clerk, it may help the quality of your clerking, but again, it depends on individuals and depends on how you're working with your MOs before deciding whether you really have to pre-clerk before seeing. So 3 parts of the plan: nursing, investigations, and treatment. And that's the main part of the end of the main part. There are some scenarios and things at the end, but I'm not sure if anyone has any questions at this point or any comments or anything. Anyone? Or any questions in particular? I mean, the main Q&A I was aiming for 6:30. Some of my colleagues were joined in. Anyone has any questions?
We have some questions from the Slido. Do you want to start answering those?
What? How do I see the questions?
Oh, I have them, so I will just feed them to you.
Yeah.
So the first one that we got is, can you do F1, F2 in the UK and then apply for internal medicine residency in Singapore?
Oh, come as straight. Some people have done that. I know at least 2 people. So one came back, I think one did F1 there and then applied straight. So no, one did F1, F2 there, then applied straight and came into residency straight. Another one did actually F1, F2 and core medical training, and then came back and then did MOPEX for a year before joining junior residency. It is possible. I would say if it's something like internal med, where there are more places available, then whether you need to work within the hospital or within a specialty before getting a space may not necessarily be true. But I think in general, be prepared that you may not be able to get in directly. Yeah. But it's possible, yeah, there are people who came in directly. Previously, when you could still apply straight out of medical school, there were people who were able to get in straight out of medical school. But whether that's a good thing or not, I think now they've stopped that in general because they realize that when you apply as a medical student, you may not actually know what exactly you want, and they think that people should have a little bit more time as a HO first, I think, before applying. So now you can't apply directly from medical school, but you can certainly do F1, F2 then and come back and apply for internal med. Whether you get in direct or not, it is possible to get in directly, but I would not assume that to be the case now. Yeah.
Thank you. So along the same lines, someone also asked, what is the application process for internal medicine / dermatology training in Singapore?
Last time dermatology, there was a 2-train program. Now you have to do internal medicine first. And then internal medicine itself is 3 years. So what happens for all the medical specialties is you have to join internal medicine. You apply, MOHH will have a deadline, so it's once a year. So you have to apply and have certain referees. Yeah, there's a criteria for like referees, how long you must have worked with them for, and then fill out a form. And then previously it was a national interview sort of station. Now they're just doing by according to cluster, I believe. So Singapore in general is split into NUHS is one cluster, SingHealth is one cluster, and then the Tan Tock Seng side is another cluster. So you apply for internal med, you apply to the specialty and the cluster. Yeah, and then the interviews are by the clusters. Yeah. So it's only once a year, the application, and then you usually know by the application is usually starts you should start around this time or soon, probably September. Interviews are then later towards the end of the year. And then you usually know by first like March, I think. Yeah. And then you start the program in July. So only one interview per year, and then they all start at the same time. Can't really join halfway through the year.
Thank you. That actually answers some people have asked also what's the application process like. So another popular question that we have received is what is the salary of doctors in their HO year? Is there anywhere online that people can find this information?
Ask Carol. It's Carol here. Thought I saw Carol's name. Yeah. Let me text Carol. I think they've certainly increased it from when I was a HO. For my friends who work in the UK and Singapore, I think by the time you take out the taxes, the take home is actually about the same, or Singapore might be a bit higher. I think when I was a HO, I think the base is maybe 3,500. Yeah. Call pays have increased, so call pays you should be quite miserable. But they just revised it last year. So as a HO, you usually do about, you have a call requirement for posting. And if I'm not wrong, it's something like, works out to be average of at least 4 calls a month. Calls that are trying to improve things. So previously you are expected to go on call after working a full day and then work post call until about lunchtime or whenever you finish your changes. But I think things have been shifting. So certain clusters do a float system. So you just do calls at night. Some have also moved towards going post call at 8 AM. So you do work like a normal, like as per normal during the daytime. Then you go post call at 8 AM without having to see patients that day. I think Carol has come in. So Carol, I think Carol, introduce yourself.
Hello, don't know if you can see me. I'm PGY1, just finished I am in SingHealth.
They want to ask you HO pay nowadays, how much?
HO pay,
Yeah.
it's 4K base pay, and then you have your calls lah. So calls is like 200 for weekday, then I think it's 320 for weekend.
Yeah, which is a lot higher last time than when I started HO lah. And then by the time you take away CPF, all that is
CPF is just 20% of everything.
So net will be what, 3 plus still. By the time you add in.
Yeah, about 3 plus 4. But sometimes they pay you late. So some months you get like quite little, then some months you get a lot. That's not true.
Yeah, and then I think it's work on PH lah. So if you want public holiday, then you get, I think probably a couple of hundred extra.
Yeah.
Yeah, they used to be quite stingy. So last time you must be like on call on the public holiday to get extra, but now it's if you round, as long as you work at least 4 hours on a public holiday, then they'll pay you extra. Yeah, so I think I found the call thing now. So call allowance has been, okay, I can't find it, but they have recently just revised the call pay at the start of this year lah. So it is better than the past.
Thank you for answering that. I think a lot of our members here are also wanting to know more about the difference between the healthcare systems in Singapore and the UK. Like, what kind of conditions do you commonly see in Singapore? Are they very different from the ones that you see in the UK?
Carol, how is it same as what you saw in medical school?
I think they are actually largely similar. I guess overseas you see a lot more autoimmune conditions. in Ireland, it was like cystic fibrosis and things like that. Over here, not so much.
Here maybe more like TB. TB is quite common that I don't think I saw as a medical student. Sickle cell I've not seen here. I mean, your common things are still common lah, like your valvular heart disease, your fluid overloads are all very common. The pneumonias. I guess depends on where you do medical school and whether your medical school is a tertiary center. That might affect what kind of conditions you see. But I think whatever you learn in medical school in general is applicable. And I think even if the conditions do vary, I don't think there's that much impact on your learning or your ability to function as a doctor lah. Yeah. So I wouldn't worry too much.
So that leads on to the next question. What challenges did you face adjusting back to working in Singapore?
Carol, do you have problems adjusting back?
Sorry, actually a bit noisy because I'm walking on the road. But I think it was like a
Actually, did you tell
system.
them where you did your uni? Maybe
So I studied in Galway, University of Galway, Ireland. And then I didn't have any elective experience because it was COVID, so we couldn't come back to do any electives. I think the main difficulty was the computer system. I didn't really know how to use a computer because in Ireland we still use the paper kind of like to round. And then other things is like how fast everything was. So in a way it was a bit of a culture shock because everything happened so fast, everything is that, especially since I started in GS, so everything was like super fast. So I think I couldn't get used to that. But after a while, just get used to it.
Yeah, I think depends which posting you start. Also, I have different challenges. So I started in like SHIM, which is not bad. Like we have about, I think each junior takes care of about 5 to 7 patients each. So that's quite okay. Of course, initially, I think my first few days were worse. First few days was like closer to 10 patients, and I am pretty sure all I did that few days was copy and paste lah. So, but after that, it's, as Carol said, a lot about using the computer system, and then also this thing about the discharge summaries, because you never do it as a medical student, and then calling families or calling other people who are calling families or calling other specialties, which you also don't really do as a medical student, which I thought were a bit more challenging. Does it matter that you have studied in the UK? I think it just means that you may need a bit of time to adapt to the system lah. But I think ultimately, you'll learn along the way. Which posting you start with is a bit of heng suay. So people who start with SGS also, which is like one of the worst postings lah. I think we have Pearly with us, who's also a current PGY1. Maybe Pearly can tell them when you graduated, from where.
Hello, can you hear me?
Yeah, I can.
Hi. Yeah, I'm Pearly. I graduated from Glasgow, and then I did my PGY1 in Singapore lah. So I came back right after graduation. I did KKH, ONG, SGHGS, then Ng Teng Fong IM in that order.
So they were just asking whether they thought there was any issues transitioning back to Singapore, and I think earlier also whether the conditions that you see here are different from the UK.
I think definitely there are certain conditions that are more common here, or things that we consider here that are much less common in the UK. For example, TB is a very, very, very big thing here. It's very, very common for us to suspect TB in patients with hemoptysis, for example lah. And then they also have like rare and wonderful things like I remember like hypokalemic periodic paralysis, which has never ever been taught in any like of the UK like lecturers that have ever been mentioned in passing. So there are things that are definitely new on the SG side of things, and also people here use acronyms like crazy. So it's very, 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 it was quite difficult to adapt to it at first lah. And even now I still find like lots of acronyms that I have to ask like, what is this? Yeah. Then I think issues adapting, also there's like quite a significant culture shock because the patient profile here is much different. I think patients here get investigated possibly earlier on in the disease. So there's a lot of, sometimes there's a lot of diagnostic uncertainty to deal with. And then we have to manage expectations along the way, which is very significant in our population as compared to the UK. I think patients there are generally slightly more grateful for the care they receive, possibly because of the healthcare system and how it works. But patients here have very high demands that especially for PGY1 may be very difficult to stomach and resolve. And then we also have, I think, quite significant demands of us in terms of clinical knowledge as well as job scope. I found that sometimes I've had to, in certain postings, I've had to sort of break bad news to the family, and mostly through phone call because of COVID now. Sometimes we do offer to see like a family conference and things like that, but as a PGY1, I think in the UK, you wouldn't be expected at all to even broach the topic of breaking bad news. So it's a very difficult, a very different field of play, I would say. Yeah.
I think along the lines of
Thank you.
acronyms, the other thing is drug names. They like to use the brand names. So
Yes.
like metronidazole is Flagyl, and then Rostavin instead of ceftriaxone, which I also took some time to get used to. So sometimes you'll be talking about antibiotics and be like, what's this? And yeah, the acronyms, or even not just acronyms. I remember we had the PGY1 briefing, our lectures before we started, and then the guy kept going ComHos. Then I'm like, what's ComHos? So apparently ComHos is community hospital, but Singaporeans being Singaporeans, a bit too lazy to say the full two words, so community hospital became ComHos. And yeah, I guess that's I think the communication part actually is a little bit more challenging in the sense that you may not have had practice about that, but I think bottom line is if you're not sure, that you should still ask. So like in medical, sometimes your seniors might ask you to broach the extent of care with the family, which sometimes may not be the easiest conversation. So what you can do sometimes is you can ask your MO, is it okay if I run through with you like what to say or how to broach this topic? And usually people are quite okay with it. It's just that if you don't ask, sometimes they just assume that you know how to do it, but it's okay to just ask if you're not sure.
Thank you. I think there are a few questions about MOPACs. So the one question was asking if posting rotations are similar for MOPACs, and if you want to do a popular MOPACs posting, is there a way or how early should you email the department beforehand?
I didn't MOPAC, so maybe Carol and Pearly can answer. I know Carol's going to be taking a break for 2 months, which I think that's a good thing about being out of place, is that you can take the opportunity to have no paid leave, which sometimes the Singaporeans, the ones who graduate in Singapore don't have a chance to because they're like not out of phase, so MOH doesn't allow them to. But I'm not sure if Pearly or Carol can advise about MOPACs.
I haven't, I mean, personally, I'm just turning PGY2, same as Carol. So I won't say I have much experience in this field, but what I've heard is from the seniors is that you just sort of email ahead to the HOD or PD or whoever and say that you're interested, possibly in that posting as a career or just the experience and things like that. Then sort of push your case along with your CV and stuff. You can do it quite late as well. I think like during the application process itself, if I'm not wrong. But of course, it's always better to be slightly earlier. But the application does open quite early. Like for example, our MOPACs, which starts 3rd Jan next year, applications are opening in 2 days time. 3 days time. Yeah. So it's quite early on. Then for the out of phase like UK graduates, for example, because I think my juniors are starting next week proper after their shadowing and orientation. Whereas I started around this time last year. So this is usually the time that we end or like transit over. Then we get a 1 month no pay leave, and then an interim posting, which you can also sort of email to try and get a posting that you want. And that should be around 3 months duration lah. Of which you will be known as a baby MO to the team and like be extra manpower essentially. So it's quite easy to get it's much easier to get difficult postings like those rare and wonderful ones like anesthesia or something. But of course you have to write in. I also know friends who wrote in to get an interim in IMH, even though it's not like on the offered list. Yeah, so you can also like that there are options available, you just have to ask. Yeah.
I will also say that with the unpopular postings, who desperately need manpower, as long as it's listed as one of the choices, then it's rare. Even if it's your last choice, there's quite a high chance of getting it.
Oh, and also this time when they sent us the email, they did highlight a few postings that were desperate for manpower. So they said like for the interim, so they were saying, oh, if you out of your kind heart decide to do this posting, they will put you a little bit more favorably up the ladder when you choose your MOPEX. So there's like a sort of compromise there lah, if you are kind-hearted enough. Yeah, depends on what you want to do as well, because I think interim as well as MOPEX is always for those who are gunning for residency, is a good time to experience the different specialties lah. Yeah, but don't be in a hurry to apply is what I heard, or don't be in a hurry to decide too early on. People are like pushing the applications further and further, or going to residency at later stages in their career. So at least that's what I heard. I'm not sure about what Dr. Chua thinks.
Yeah, I think you should think carefully before you commit yourself. And I mean, I think your goals in life or what you want in life, you may not be sure yet. And I think there's no real reason to rush into it. Yeah, I think if you've decided, fair enough. But if you haven't, then just take the time to explore and MOPEX around first.
Thank you. We have someone that is actually going to be starting at Ng Teng Fong in internal medicine and is asking for any tips.
No, I didn't do Ng Teng Fong. I don't know if any of the other. I think Carol and Buddy both did at SGHDIM, right?
No, I did mine at Ng Teng Fong. I just finished actually.
Okay.
Firstly, condolences. It is a battlefield. So Ng Teng Fong workload is in comparison to the other hospitals I was at, quite high lah. I think in general Singapore is very, very overloaded, but Ng Teng Fong especially is quite jialat. I'm not too sure why the manpower allocation is not equal as well lah, in comparison to the demand. But in terms of tips, I think might be easier if this person messages me for like very specific stuff. But I think in the general tips for PGY1 still apply. Yeah, I think there are some specific stuff to Ng Teng Fong. For example, like you for all referrals you have to call before like 11. Things like that. They might be a bit more specific to Ng Teng Fong, but I'm not sure this would be the best place to share lah, because it's like nitty-gritty stuff. Yeah, they can message me. No worries.
Thank you so much.
But Ng Teng Fong is not a great place to go.
I think Shu Wei has joined us. I mean, we can just let Shu Wei introduce himself.
Hi, I'm Shu Wei. I'm one of the medical officers in internal medicine right now. I'm in the second year of residency. Like all of you, I studied in UK. Came back to do my HO lah. So that was about three years ago. So if there's anything you guys want to ask, and if I can answer, I will try to, especially some of the administrative things that you might want to clarify. Just feel free to ask lah.
think there's a question in the chat about GMC license. I mean, GMC license, SMC license, I don't think SMC accepts GMC license. For all of us, we have to, PGY1 are all provisional license. Then after that, it moves to a conditional license, and then conditional license has different levels. And then to go from conditional to full, usually you need to work at least a few years, and then you need to get your the HOD at that point in time for whatever posting to write a letter of recommendation, and then that has to be approved by SMC before you can convert it to a full license. And without a full license, you cannot practice in private lah. If let's say you're thinking about going to private land early, yeah. I do know of some people who did. I think rarely, sometimes people get their GMC license while working in Singapore as a HO, but I think there are quite a lot of tick boxes to fill up, so I didn't actually do that. And after I also thought about this GMC license thing, whether it's worth staying in the UK for F1 to get a GMC license. And I think at the end of the day, I figured that personally, I didn't think that was worth it, because number one, even if you get a GMC license, if you want to maintain your GMC license, you have to pay them every year. And number two, I feel that the UK is always short of manpower anyway, and if you really want to go back to work in the future, I'm sure there'll be some way of getting back in without actually having a GMC license from doing F1 there. I don't know what the others feel about it.
Was that you just have to essentially do FY1 again, even as a senior?
Because even
then
if,
you
I
can
don't know, when I was there at that time, there were quite a few registrars who clearly didn't, like from Sri Lanka, for example, clearly didn't study in the UK or graduate in the UK. And then they just came over and then they like shadowed for like a month or so and then went there. And then there are a few of my previous MOs also went to the UK to work lah. So I think if you really want to, you can go. I'm not sure if you really need to repeat the F1. I don't know. I feel like there should be a way to get around it.
I think the one might be via the international graduates route. There's some kind of application and some exam to sit, if I'm not wrong. Because I had some Malaysian friends who wanted to go as well. But it's a little bit more complicated. But it's not impossible. They're always wanting manpower, definitely. And now they are like on the verge of going on strike for a full pay restoration, from what I heard.
I don't think you need to do FY1 again. But when you go back, you may be part of their so-called MOPEX bank, so which is not a trading position. Position. So regarding the GMC, I do recall quite a number of people wanting to do F1 in UK first, because it's easier to get the GMC registration first, rather than going back. But sometimes the paperwork to go back to UK to work again is probably more tedious than submitting application for SMC registration. I mean, Singapore is a bit better in terms of administrative matters. In UK, I'm sure everyone have gone through. It takes a while, and it might not even be successful.
Thank you. Someone would like to ask if the seniors in the team provide a supportive environment in Singapore as compared to the UK.
Can ask Carol, she was in my team last month.
I think generally, it also depends on like the posting, but I think generally people are generally very helpful, a lot of support given, and you can always ask if you have questions. Because if you don't ask, people also assume that you know what you're doing and you know the plans and things like that. So always ask. I think in generally in medicine postings, you get very good support and guidance. And even your MOs, like sometimes the more senior ones, they do tend to check through your work just to make sure that things are done properly. And they help you if you have difficulties, for example, very difficult like family communication, they can help you with that as well. So I think in more busy postings, especially in surgery, generally, seniors may not be really around to help you because your MOs might be like clinic and OT, then your registers are also in clinics and OT. So generally, it's also a bit hard to reach them through text. So if something urgent, you either call your other HOs who are like in the same team or in other teams around the ward to help with certain, like CTSPs. If not, you can just call your seniors who are the OT, and then you just replace a loudspeaker and you ask a question, and then the whole OT will hear your question also. Yeah, so I think generally depends on posting, but most people are generally very willing to help. But I think sometimes it's just a bit more busy, so it's like a bit limited lah. So I think it's good to really ask for help when you need, and then ask very directed questions also. Yeah.
Maybe I share with you why I came back to the UK. Sorry, from the UK to work in Singapore and do my HO-ship here. I actually thought that most of the I kind of inclined want to come back to Singapore pretty much from the start. I know that it's probably work-life balance as compared to the UK not that good, but 2 weeks before my final year exam, I was actually rounding the patients with my consultant alone. When I need someone to help to sign the drug chart, I need to go to another team in another ward for them to prescribe the medication. I don't think that was right, because you can't have a medical student just rounding with a consultant 2 weeks before the exam. You shouldn't, and very unlikely to get this in Singapore. There's always someone that you can go to more easily for help. There's always a sister team that you can borrow manpower from, or you can also get advice from. So yeah, COVID times made manpower quite bad, but doesn't mean that the support isn't there. So I think last month, my sister team only had one HO. So I forced a HO to sit with me with my team. And she required any help or advice, they can just talk to me, just beside me only. That was something that I thought it was quite nice, but I didn't experience this in the UK, unfortunately.
Thank you. I'm not sure if you guys will have a lot to add on this, but I think people were asking at which point would be advisable, or whether there are advantages or disadvantages for coming back as an MO or as a consultant, so not for HO-ship.
I know one of my friends doing pediatrics in the UK. I mean, she has thought about coming back halfway, but I think it's quite a difficult one. So she'll probably finish her full pediatrics training before coming back to Singapore. There are some people come back as consultants. I know 2 who came back as MOs. I don't think there is much of a problem per se. Well, okay, that I guess depends on your working style and what you want lah. So I think I know at least 3 people who came back as MOs. 2 didn't have any problems. One, as I mentioned earlier, went straight into IM residency. Another one MOPEX for 1 year before going to IM residency after having already finished core medical training, actually. Another one came back, as a PGY2, and then MOPEX in PEDS for 1 year before getting to pediatrics training in Singapore. Actually, no, another 2 actually, who came back as MOs and then MOPEX, and these other 2 had a bit more issues coping and coming back to Singapore to adapt in terms of I would say probably the pace of the posting wasn't the friendliest for someone who's just come back from the UK, and then having to learn a whole new computer system and how things work didn't quite help. I'm not sure whether calls will be quite different, but possibly, because on call, the workload in Singapore calls is also quite heavy. when should you come back? I guess it really depends on what you're looking for. So if you really want to just experience working life somewhere else, I guess it's not wrong to just stay for a few years and see whether you like it. But everyone will have different reasons for doing different things. So I mean, personally, I just came to Singapore just because my family's in Singapore. So I didn't really have such a huge thing about should I stay in the UK to work or not. Some of my colleagues, some of my friends just wanted to stay there to just experience something different. So I think it's not a problem if you stay there. When to come back depends on what you want. If you have already started training program there, it might be easier to finish up there before coming back to Singapore, because if you come back halfway through, like my friend did core medical already and then came back, you kind of have to start from junior residency again in Singapore, because they don't recognize kind of any sort of junior residency training equivalent. So you need to be prepared to start all over again. If you just want to experience a couple of years of working elsewhere and then come back to Singapore, I think you just have to understand that you have to remain highly adaptable, because things move at a different pace and things just work differently. So we just have to be prepared for that. I don't think that should deter you from getting the experience that you want, but that should be just something that you have at the back of your mind.
Let me add on that. So the amount of consultant jobs in Singapore, is not many. I must say. MOH plan in a way, the number of people they take for residency it pretty much correlates to how many of them going to senior residency and eventually giving them a job as a consultant. I know I've been asking around. It's probably very difficult for people who are trained overseas to come back to Singapore to get a consultant job, unless you're one of those who are very experienced and have a lot of research papers and directors of a certain team in the UK or in a hospital. Then basically they want you to come back for administrative or leadership roles. But if just to come back and say, you finish respiratory medicine in the UK and you come back to Singapore and you hope that there is a consultant position for you, it's highly unlikely. Reason is because they created the positions or they're leaving this position for those that they have already trained. It won't be as easy as for someone to just come in and take the job position. It's just how it is. I want to do neuro, and if somebody, I'm okay, but neuro always have job, so they may get consultants from UK, but I think cardiology is quite difficult. They rather take their own people, the people that they train themselves. Is kind of how life is. People will always. My wife graduated from Ireland. She came to Singapore. Start a life with me, basically. But she's Malaysian. Very difficult for her to come back as an MO because the pace is absolutely different. In UK, I recall not every patient get rounded one, right? It's only those who are unwell. You just tell the team, okay, you guys pop by and see this person over the weekend. But they just, if the patient is stable, they don't get seen on the weekend. But over here, we pretty much round as efficient as we can on the weekday with as a manpower. You don't get this in the UK.
I think same with exits. I remember chatting with my friend in the UK. I think there's no such thing as exit rounds there. Yeah, no weekend rounds, no exit rounds. I think the thing about consultant jobs in Singapore is quite true because in places like the UK is so big, people really just give consultant jobs or training positions just based on like CV. But Singapore is so small that for things like jobs and training spots, they do rely a bit more on having seen you work before, have worked personally with you before as well, and indeed the manpower planning depends on the manpower planning is such that whoever they train is the number of consultant jobs they're expected to have. So like in cardio, manpower for reg levels are very shit, but they don't take more regs because if they do, then there'll be not enough consultant positions. Yeah.
Thank you. So there are some questions about free time when you're in HO. The first one is, do you get time off to study for postgraduate exams such as MRCP? And the second question is it common to use free time to do additional work in certain clinics, theaters, or labs to be more competitive in getting residency positions as a HO?
How?
I think I can, as a PGY one, there are no training leave. There's no training leave. MOs they have. So as a MO, you can apply for like a few days or even a week or a few weeks of training leave before you so that you can study for exams. But in HO, there's no such thing. In terms of free time, I think really depends on the workload. As I mentioned, our working hours are a bit crazy. So depends on how you manage your time, whether you have any energy left for extracurricular activities to boost your CV essentially. Because I know that certain specialties, it does put you at an advantage if you have done some of the postgrad exams already. But one is not a confirmed requirement, like it's not a black and white requirement, so they don't have any reason to grant you this kind of like training leave lah. And two, I think you as a HO you also need a lot of time to yourself to take care of yourself and prevent burnout, because burnout is very, very real. So I think, I suppose for the high flyers or people who really are like super damn efficient, they can get some stuff done. Like I do have friends who go for additional clinics as well. For example, if they are on a rest posting where their day-to-day workload is a bit better. For example, like SGHGS breast, for example, they don't have many inpatients. Then sometimes if you're not assigned to clinic or OT, only specific to breast because breast has very little inpatient work. So some of the HOs go to OT and clinic. But even if you are like assigned to inpatient or not assigned to any specific job, you can also go in and like ask around and then go in for OT if you are interested, or clinic if you're interested. But I think also because of COVID and things like that, they may not want too many people around. So that may be an issue as well. But there's always no harm asking lah. People are generally friendly to people who want to learn. So if you have the look that, oh, I'm really, really keen to learn, I'm really, really keen to possibly join your specialty like at a later stage, then that kind of attitude will bring you far lah. Yeah.
In terms of exams expected, like I know anesthesia, most people have to complete the first exam before applying. MRCP, not really. I know a few people who were from NUS, but they did MRCS like the earliest possible dates. So free time out of HO, I mean, I remember that time when I was in SGHGS, one of the posting that was really quite bad. Like I came in at 5:30 or 6 every day, and I probably left at like 9 p.m. on most days. SGHDIM, I probably came in at 6:30 or 7 and then went home by 5 something most of the time, except maybe my first month when I first started, there were also days where I left way past dinner time. So depends on the posting, depends on the manpower. In general, you are expected to round at least 50% of the weekends. So that's your weekends gone. And then calls mentioned earlier, probably 4 to 5 a month lah. And then usually post call, you can't do much because you're like comatose. Yeah.
I'm just looking at the MRCP website. Okay, so this is what happened. I as a HO, those who want to do MRCP Part 1, you will not be able to apply for Part 1 until you finish your HO-ship. So what I did was to finish my HO-ship that whole year. I had absolutely no time to study at all. All my time is dedicated to either sleep or work, or plus minus family. after I finished my housemanship year, my PGY1, I had about 1 month of no pay leave. And this is something which MOHH told me to take because they needed to convert my license from provisional to conditional licensing registration. So I took that 1 month and marked for part 1. Carol, I think she's finishing her HO ship in these few days. If she intends to take MRCP part 1, the exam date is on the 30th of November, and the application date is about a month from now. So it's about it's on the part 1 website. It's 26th of September. So you do have time, say about 2 to 3 months before the exam, and you can actually study for that. But that's when you are an MO. You may be in a rotation or interim posting as a medical officer where you can study for part 1. That's exactly what I did. Managed to pass. So it's possible. It's possible. And having 3 months from now till the exam date is certainly more, very doable. Also, in HO, don't expect that you have time to study or to go for additional clinics, because the clinics is actually meant for the MO. Then conferences also quite difficult because there's only a certain number of days you can miss as a HO. You know, you have to repeat the posting. If you miss more than a certain number of days on 2 postings and you or more, you will need to repeat HO ship.
I think the thing about another thing relevant to, I guess, all these exams and stuff is there's a personal training fund. So although you have no training leave, as HO, you do have personal training fund. So you can use that to pay for some resources or the exam fees. Though some exams are quite expensive, so may not fully cover. But there is some sort of funding. Compared to in the UK, my friend, I don't know whether it's because she was in pediatrics training already, but she seemed to have tons of training leave, and she had she could take a lot of time out of day-to-day work to do extra training or conferences and things, which are quite hard as a HO. And I think even as a MO side, even though you have all these leave in place, whether you can actually take them depends on the manpower constraints for that posting and may or may not get approved. And in general, I would say leave approval tends to be quite late and last minute. Although training leave has the highest leave priority, you still can't assume that you'll necessarily get it. And leading up to the exam, different departments have different policies, but let's say you have MO and you have training leave, they usually only let you take training leave for the exam date itself. And then all the days leading up to the exam, if you want to study, you have to take it as annual leave.
Thank you. So I think we're going to ask just one last question. It's regarding Singaporeans as IMGs coming back. Is it very difficult / what is it like to get residency, or is it like, how difficult is it, especially in the highly competitive ones?
I think internal med not so competitive. So I did internal med. So me and Shui are both internal med. So I think it's probably one of the easiest ones to get in as IMG, right? Because there are so many slots.
So for SingHealth, there are 60 slots as compared to NUH and Tan Tock Seng. The number of slots, I'm not sure, but it's definitely maybe even half to or 1/3 of what SingHealth is taking. I think, is it easy to get into residency? I don't think there's a short answer for that, but they are looking for a variety of people to make up the batch of the residency. So basically, those people who apply for residency, not only it's not only just IMGs, it can be Duke, Yonglulin, LKC. So it quite a good mixture of it, and I think they want to see how people from different background come together and make that year be unique in certain ways so that people can help to cover, because no one is perfect, right? There's I have some weaknesses and some strengths which I can help to cover other people's weaknesses, and other people's strengths can cover my weaknesses. So that's how they want to make the batch of residency is. I think okay, regarding how difficult it is, I did 10 electives before coming back to Singapore as a houseman. I think electives for your batch might be quite difficult, especially during COVID. Even with that, and I used to work in SGH, even with all this and familiarizing myself with the system, it was still a challenge. I think the most difficult challenge which I experienced is I forget that I'm a doctor, and I always think that I was a medical student. So sometimes I forget to check things. This will happen across everybody, not just the IMG. But I think this was something was quite difficult for me to go through. It was until my second IM posting that when I started to become a bit more comfortable with internal medicine. Then my last posting was auto, and they know that I did 2 posting of IM, so I was golden to them. And they know that I want to do IM as well. So it takes a while. It takes a while to be familiar with how Singapore works.
Yeah, I'm not sure if Carol and Pearly are y'all planning to apply for anything. I think Carol not yet. I don't know about Pearly if you have any interest or whether you've heard anything about applying for whatever you're interested in.
I'm more surgically inclined so I was looking at GS and things like that. For them, for that side of things, I think there's significantly less sports. The last time I checked numbers a couple of years ago, it was like 9 residents for Sing Health compared to the 60 for IM. For GS, is much less. So for these kind of specialties, especially, they definitely look for people who have worked with them before. So it'll be good to adapt posting with them, or at the very least a posting possibly within the same cluster, or even at a stretch somewhere else but under the same specialty, because they still talk. Singapore is very, very small. But with regards to like different clusters and things like that, so you also have to see whether you like the place. So like the culture, because every cluster is different. So I would say doing a MOPEX there is quite important Yeah, although you may not need to like go through all the 3 clusters, then you decide. Maybe like you go into one and you think that, oh, this feels like it suits me. But I'm also not very sure yet about what I want to do, because as we all mentioned previously, like in Singapore, the work-life balance is quite it's not so conducive compared to other places. So if I go into GS, it's gonna be even worse. And I think the dips are with HO year as well as Reg Life that the work-life balance really gets quite difficult to maneuver around. But hopefully by the time you reach that level, you'll be better at managing time. Yeah. I myself am still struggling. So it's not an uncommon thing to experience. Yeah. I don't know about training in the UK because it's very portfolio based. And here, I suppose for GS, they also do want the MRCS Part A at least, but it's not a must for you to get in. It's a good to have, or what they say in the open houses
I guess
the most.
It might be easier if you finish before starting, then you have one less thing to worry about during your training.
Definitely. But also, I heard that it's like quite important to show yourself, make yourself known, and then like a good attitude is like brings you very, very far. That's what I've heard, because I think I've had peers who may not have endeared themselves to the department, even though they said they really, really wanted GS or whatever kind of suspect. So going in with the right attitude is very important, because we are definitely much less familiar with the system compared to the local graduates. Yeah, so we do tend to struggle a little bit more.
I think that it's really going back to Singapore being very small, because actually it applies to your MOPEX application as well as your, okay, I can say this because I know that within my department, how we select people for MOPEX is we'll get a whole list of MOs of MOHH, and then whoever who's managing the MOPEX will show the list to the other people in the department and say, hey, who's good in this list? Who should we try and get from this list? So I would assume that actually things probably work similarly in other departments. And it's precisely because Singapore is so small that when it comes to things like residency applications, I think actually whether you're IMG or not doesn't matter so much. It's more of when you work with them and what kind of impression you get. And in the same vein, I also know of cases where unfortunately someone made an unfortunate mistake, and in Singapore in a way it's less forgiving because then it's such a small place that everyone remembers it, and actually sometimes people get blacklisted for this kind of thing, and then they have so much difficulty in getting a residency because of that one incident that happened like 3 years ago that everyone made it such a big incident that everyone can't forget, and that's why this poor guy can't get into residency. So things like that do happen. So I think coming as an IMG, I think rather than taking it as because I'm going to have difficulty, I think going in with the right attitude is probably what matters the most. And it's not just within the specialty of interest, but I think it should apply to all postings. And I mean, people from different departments to talk to each other as well. And definitely that's the key point. I've had friends who applied, IMGs who applied for GS, and I think they MOPEX for about a couple of years. Another friend who was from Manchester, and then he's, I think, going for auto, has MOPEX for about 4 years before getting in. So different specialties have different lead times before getting in. Yeah.
Thank you so much to the doctors for answering all the questions. I'm going to be handing back to Ruth now. I think there were a few questions that we won't manage to answer. I think Dr. Chua said she'll be happy to share her contact details, and we will be sending that out to everyone later. And I'm not sure if Dr. Chua's colleagues would be happy for that as well. Yeah, okay, so we can just, you can send them to Dr. Chua and then we will send them out to the participants here. But thank you so much. I'll hand back to Ruth.
Okay, amazing. Thank you so much to all the speakers. Would everyone be okay to turn on their cameras right now? Because we're going to take a photo. I think Ping Xing will facilitate this.
Yeah.
Do you want to tell us like when to smile?
Yeah. 3, 2, 1, smile. Okay. Thank you.
Thank you.
Thank you.
Thank
you.
Hey, thanks, Dr. Chua.
Thank you.
you, boss. Bye-bye.
Bye-bye. Yeah, feel free to contact me if there are any questions, or if I can't answer, I can try and help to find someone who might be able to answer your questions.
Okay, sure. For the participants, before you leave, right, could you fill in a feedback form? So I think we can reshare the screen so that they can see the link. So take about maybe 1 to 2 minutes to fill in the feedback form. I've also posted it in the chat.
Thank you so much to the doctors. I believe they are free to go. And we will be sending out the contact information to our participants today. Yeah.
Thank you.
Thank you so much, everyone.
All right. Bye-bye.
Thank you.
Thank you for this.
Thank you. recording.